So I'm Dr. Holly Whiteley, and I am going to be, first of all, I should say that I'm a researcher from the Centre for Health Economics and Medicine's Evaluation, or CHEEM for short. So we're based here at Bangor University, and I'm going to be introducing the economic evaluation of the KiVa programme that we conducted alongside the Stand Together randomised controlled trial that Mariad has just introduced. And just before I crack on, I just wanted to say I'm here presenting on behalf of Professor Rhiannon Tudor-Edwards, who's Professor of Health Economics and also co-director of CHEEM here at Bangor, and also obviously on behalf of the wider Stand Together trial team, some of who are here face to face today. It's nice to see some people that I've only ever seen on Teams. And a huge thanks to Judy for the invitation to speak today. So in this presentation, I'll just briefly talk about the prevalence of bullying in the UK, and then I'm just going to reiterate some of the information we've already heard about the impacts of childhood bullying. I'll talk about the role of health economics in the Stand Together trial. I'll introduce our economic evaluation of the KiVa programme, and then I'll present the results of our cost analysis of the KiVa programme and its usual and its comparator, usual practice, in UK primary schools. So in terms of prevalence in the UK, the most recent 2023 Anti-Bullying Alliance report indicates that almost 1 in 4 pupils in England reported that they were bullied either a lot or always. So that's not just almost a quarter of pupils that are experiencing bullying. Their experience of bullying is significant. And what's more, pupils in receipt of free school meals and those with special educational needs or disabilities were significantly more likely to be frequently bullied. In Wales, a recent report from the School Health Research Network indicates that nearly half of primary school pupils report being bullied. And again, there's evidence of maybe a social gradient in pupils' experience of bullying in school, with pupils from less affluent families reporting slightly higher rates of bullying compared to those from more affluent families. So in terms of the short-term impacts, the Anti-Bullying Alliance report, data from that report indicated that those pupils that experience bullying, but also those pupils that bully other pupils, so victims and perpetrators, both report poorer school experiences and poor well-being compared to those pupils who are not bullied. In terms of findings in the published literature, with regarding short-term impacts, just reiterating some of the information that Lucy's already shared with us today, bullying has been associated with greater mental health service use, school absenteeism, and poor educational outcomes. And then, as Lucy has also referred to today, childhood bullying can actually have long-term impacts. So it can have an influence on a child's life well into adulthood, and we call this the long shadow of bullying. So, for example, experience of bullying victimization in childhood or adolescence increases the likelihood of experiencing anxiety and depression into adulthood, as touched upon by Lucy. But also beyond health, childhood victimization has been associated with socioeconomic status, impacts on social relationships, perceived quality of life, and also even impact on cognitive functioning in adulthood. And these long-term impacts can also be important for the perpetrators of bullying, which, for example, violent and antisocial behaviour and also illicit drug use into adulthood for those pupils that have actually bullied others in school. So we can see that bullying therefore has both short and long-term consequences across multiple sectors, not just within health. And it's these detrimental multi-sector life course consequences and their associated costs that actually highlight the importance of a preventative public health approach to reducing childhood bullying, which we heard about right at the beginning of this morning. And this is particularly important as we know that both the number of children and adults experiencing mental health issues continues to increase, and yet the resources available to deal with these problems become under increasing pressure. We are all very aware of how much strain the NHS is currently under. So investing in an effective and cost-effective preventative approach early in the life course, for example, investing in a school-based anti-bullying programme like KiVa, could help us reduce this high demand on services and their associated costs going forwards. And you can see this illustrated by the red dotted line on the graphic here. So this is where health economics comes in. So economics is the study of how society uses or could use scarce or finite resources to meet its wants and needs. And health economics looks at this question of resource allocation in the context of not only healthcare, but also in the context of other sectors such as social care, education, where we're looking at preventative interventions that could have impacts on health. And as a health economist, when we perform an economic evaluation, we're looking at informing the cost-effective allocation of these finite resources, these shrinking resources really, across alternative interventions or options. And we do this by weighing up their relative costs and benefits. And this is exactly what we're going to do, or what we are doing for our economic evaluation of the KiVa programme. We're weighing up the costs, relative costs and benefits of KiVa against usual practice to see if, to try and inform decision makers regarding its investing in KiVa and implementing KiVa across the UK in the long term, which obviously we know is already underway and there's great progress being made, and this is just adding to that evidence base. So just to say, we've mentioned usual practice a couple of times. Maggie had mentioned it, I've mentioned it. For the purpose of the economic evaluation, usual practice was defined as a school's usual approach to addressing and preventing bullying. And for this, in England, we identified the anti-bullying content from this mandatory personal, social and health and economic education curriculum that Maggie had mentioned, and also in Wales, the anti-bullying content from the mandatory personal and social education curriculum, which, just to note, I'm sure many of you are aware, it's been recently replaced by the wider health and wellbeing area of learning and expertise within the wider Welsh curriculum. So in terms of our research objectives for our economic evaluation, we first need to identify and estimate the costs of delivering the KiVa programme compared to usual practice in UK primary schools. Once we have these costs, we can then weigh them up against the benefits, which we assess by using the effectiveness evidence. So the evidence generated by the Stand Together trial, looking at the effectiveness of KiVa in schools, we use that evidence alongside our costs to explore the cost effectiveness of KiVa compared to usual practice. And we can do this using a range of different types of analysis, which we can take from what we call our health economics toolbox. So we've got lots of different types of methodologies that we can use to explore cost effectiveness. But before I mention which ones we've used here, I just wanted to note that the actual perspective of an economic evaluation is important because it informs the choice of the costs and the benefits, or what we call the outcomes, that we're actually looking at and considering when we're weighing these things up. And just to note that our analysis is taking an education sector perspective, so we're focusing directly on those costs and benefits experienced by schools as a result of implementing KiVa versus usual practice. And also, just to say, it's really important that we consider equity in our economic evaluation, because as we've already noted, there's evidence of a social gradient in pupils' experience of bullying. So when we do our economic analysis, we want to explore whether or not vulnerable or disadvantaged groups potentially benefit more or less from programs like KiVa. So on to the actual types of economic analysis that we selected to do. We chose 3 types of cost effectiveness analysis: cost utility analysis, cost effectiveness analysis, and cost consequence analysis. And I just wanted to quickly run through each of these in turn, and then I'll focus on the cost analysis and our results of the cost analysis. So very briefly, cost utility analysis involves comparing the costs and outcome or effect of an intervention and its comparator. And in this type of analysis, the effectiveness of an intervention is measured using a single measure of effectiveness, or what we call health benefit. And this is often something called a quality adjusted life year, or a QALY for short. So the QALY is what we call a generic preference-based non-monetary measure of health. And just to try and keep it short and sweet, we estimate QALYs by measuring health-related quality of life, basically before and after an intervention has been delivered. And so to measure health-related quality of life, we use something called health utility scores, hence the name cost-utility analysis. And we can measure these health utility scores using different types of questionnaires. And for this particular trial, we chose the Child Health Utility 9-dimension measure. So this is, again, a generic preference-based measure of health-related quality of life that was developed for use with children, and it's actually been validated with use for 7 to 17-year-olds. Now, Q9D, it uses or consists of 9 different questions or dimensions, hence the name 9-dimension. And these dimensions have been identified as important to children, and you can see these on the left-hand side of the slide here. And then each dimension or each question has 5 different response levels, and I've included an example of what the questionnaire actually looks like on the slide for those that are interested. And basically a child or a pupil that reports no problems across these 9 dimensions will get a score of 1 for each question, and that will give you 9 ones, which is the equivalent of a health utility score of 1, full health. And the more problems that a pupil will report on these dimensions, the lower their health utility score will become, the closer to 0 on that scale, 0 to 1 on the previous slide, the child will become. So in this trial, like I said, we used these health utility scores before and after. So at baseline and follow-up, pupils completed this Q9D questionnaire, and then we used those results to estimate our QALYs. And once we have the QALY, we then weigh these up against the costs in something we call an incremental cost-effectiveness ratio. I'm not going to go into too much detail here, but basically this is expressed as a unit of incremental cost per incremental QALY gained, and basically it indicates how much extra KiVa costs to produce 1 additional QALY for primary school children compared to usual practice. So it's basically how much are we willing to pay for an additional QALY for primary school pupils. And I say willing to pay, the National Institute of Health and Care Excellence, or NICE, advocates the use of QALYs in the economic evaluation of health interventions, and they have actually set a general willingness to pay threshold of 20 to 30,000 per QALY gained to help determine if an intervention is considered cost effective or not compared to a comparator. So when we complete our economic evaluation, if the ISA, this incremental cost effectiveness ratio, we estimate is equal to or below that 20 to 30,000 threshold, we would consider KiVa to be cost effective compared to usual practice. So that hopefully gives you a bit of an idea of what we're looking at when we're estimating these ISAs. Now, with respect to considering equity that I mentioned before, we can basically repeat this analysis for different subpopulations, so that we can see whether or not cost effectiveness varies between different groups of pupils. Now, some recent studies have actually found a weak correlation between Q9D scores and reported bullying victimisation in secondary schools. So if the same turns out to be true in our trial scores for the Stand Together study, QALYs, this single measure of health benefit, may not actually fully reflect the effectiveness of something like the KiVa programme. So considering this, we decided to conduct what we call a secondary analysis, and we're focusing on now a cost effectiveness analysis. So this is very, very similar to cost utility analysis, but it uses, again, a single but more specific measure of effectiveness that's actually directly related to the expected impact of the intervention. So for here, we're actually considering the primary trial outcome that was used to explore the effectiveness of KiVa, and that was pupils' self-reported bullying victimisation. And so here we will then look at the incremental cost of KiVa per bullying incident avoided. So it's a slightly different metric when we're estimating our incremental cost effectiveness ratio. But just to say that there's no willingness to pay threshold that's been established for this metric. So it's more a case of people looking at our ISA estimate and then interpreting it themselves to say, how much are we willing to pay for each bullying incident avoided, rather than using the NICE threshold. And again, just quickly, we can do subgroup analysis for this to explore equity. Now finally, we're in the process of completing a cost consequence analysis, which is a much wider type of analysis and actually involves the comparison of all the costs of KiVa and its comparator with a much wider range of outcomes. And we actually used, for this, all of the outcomes measured in the Stand Together trial, which Magyad has touched upon already. Now, I really wanted to make sure I could include our cost analysis, so just moving on. With respect to our cost analysis, so to say that all three of those previous methods that I've just outlined, they all require a cost analysis as the first step. So we actually need to know the costs of the KiVa programme and usual practice to be able to do all the jazzy stuff with the incremental cost effectiveness ratios, etc. So with respect to our cost analysis, we focused on the direct costs of the universal components of the KiVa programme. So these are the KiVa lessons and the whole school resources and activities that were implemented, rather than the indicated actions. And in terms of the assumptions underlying our costing, we assumed that 70% of KiVa lessons were delivered in our trial intervention schools, and this is in alignment with the trial's definition of implementation fidelity and this intention to treat principle. So we're assuming that 70% or 7 out of 10 KiVa lessons were delivered for each class. And then we've also assumed, or we've used information from trial schools to say that on average 40% of the PSE, PSHE curriculum overlap with the KiVa curriculum. And therefore we're using this to try and estimate this anti-bullying element of these mandatory curriculums in schools, costing that and then comparing it to the cost of KiVa. So in terms of the actual cost of KiVa, we categorised our costs into one-off or non-recurrent costs and ongoing recurrent costs. So these one-off non-recurrent costs included the cost of staff training and the cost of purchasing all of the KiVa materials, including the manuals, so that schools could begin implementing KiVa in schools. The ongoing recurrent costs included the KiVa programme registration, that was an annual fee for schools, and it also included the preparation and delivery of the KiVa lessons, which we're kind of assuming would actually continue beyond the trial. And when we consider these together, the non-recurrent and the recurrent, this gives us the total cost of the first year of setting up and delivering KiVa in our trial schools. And then the cost of usual practice included staff time spent preparing and delivering PSE and PSHE lessons as our comparator. So very briefly, in terms of our actual results, we estimated that the total mean education sector cost of KiVa in the first year of implementation and delivery was £38.18 per pupil, compared to £17.40 per pupil for usual practice in control schools. So there is a difference there. And you can see from the table here that the KiVa training was the largest one-off cost component at £15.15 per pupil. So in terms of just looking at the ongoing or recurrent annual cost of KiVa, which we would assume would be the cost going forwards after the first year of setup and implementation, these were actually much lower for KiVa and more comparable to the cost of usual practice, just £19 and 5 pence per pupil. So much more comparable to usual practice. Now, we don't have our final results yet regarding the effectiveness, so I can't actually present cost-effectiveness analyses in the whole. But what I can say is that we would consider KiVa to be a low-cost school-based intervention. And this is especially when we compare this 38 and £19 cost per pupil, this is annual cost, so this is per pupil per year, when we compare that to the UK Educational Endowment Fund guidance, which considers a very low-cost school-based intervention to be less than £80 per pupil. So when we look at these costs against this, almost this threshold of £80, we could say it's a very low-cost intervention. And now we're just waiting for effectiveness results from the trial so that we can then present those cost-effectiveness estimates. So, thank you so much for listening. That was a little bit of a whistle-stop tour of our economic evaluation, and I'm very happy to take any questions that you might have.